Good. So just share the screen and start the presentation. Can all of you see my screen?
Yeah, it's clear. Yeah.
Perfect. Okay, let's go. Okay, so good evening, everyone, and it's me again, Mohammed Hashim. I'm a foot and ankle consultant at Wexham and Heatherwood in northwest London in the UK. Today is our third lecture in the review course, foot and ankle course under the umbrella of Orthobema. I will speak today about Pes Cavus, rheumatoid foot, and diabetic foot. So this is where I come from, Heatherwood Hospital in Ascot area in the northwest London. And again, this is the YouTube channels where all the educational activities we're running will be there. It's my educational channel and the Orthobema channel. So quick basic start, which is very important for all of you to understand all the terms we'll be running through in this lecture. You need to understand what is talibus, and talibus is two words, tali and pes, and then you need to understand the different positions with these different names. So when we say talibus, tali is the ankle and pes is the foot. So any deformity related to pes, it is deformity of the foot. Anything related to the tali is deformity of the ankle. And when you have the foot and ankle deformed, this when you say you name the deformity as talibus. So the commonest one is talibus, congenital talibus equinovarus or CETV. And basically, because it is a deformity of the ankle and the foot, we call it talibus. All other deformities which is related to the foot, like the cavovarus we're speaking about today, like the Pes planus or Pes planovalgus we spoke about last lecture, they mainly deformities of the foot. Ankle is not involved. That's why we called it Pes. So talibus means congenital deformity or acquired deformity is mostly congenital, which is affecting both ankle and foot. If ankle only, we call tali, and if foot only, we call Pes. So you may have a talibus cavus, which means high arched foot, because there is an element of dorsiflexion of the ankle. I will show you in a minute how the ankle is involved. It could be an equinus, means plantar flexion. It could be a calcaneum, means dorsiflexion at the ankle. Could be valgus, which is a pronation, which equal eversion at the ankle, and in the hind foot, and valgus or abduction in the forefoot. And again, we understand that because of the configuration of the subtalar joint, you cannot have these two movements alone without blunt flexion in the ankle. So to have an abduction and eversion, your ankle has to be dorsiflexed, and to have an adduction and inversion, your ankle has to be plantar flexed. So talibus valgus, which equal pronation, which is equal dorsiflexion in the ankle, eversion in the hind foot, and abduction in the forefoot. And the other way around, supination, which is equal plantar flexion in the ankle, inversion in the hind foot, and adduction in the forefoot. So we speak today about Pes Cavus, and you can easily spot this patient have a high arched foot, plantar flexed first ray, and a varus of the heel, and this is by definition a Pes Cavus. What if you have plantar flexion of the first ray only without varus in the heel? This is an uncommon condition which is called plantaris. So the difference between cavus and plantaris, both of them are deformity of the foot, but cavus is deformity of the forefoot and hind foot, which equal plantar flexion of the first ray and varus of the heel, while plantaris is only forefoot plantar flexion without varus heel. So if you have a cavus without varus heel, this is not a cavus, this is plantaris. And once you see a Pes Cavus, you have to think about neurology. This is very, very, very important. There is no option, even if you are sure this cavus is idiopathic. Again, you have to exclude the neurological causes. And a lot of neurological causes can cause Pes Cavus, and we'll go to this in a minute. How this patient will present to you? This patient will present to you mainly with metatarsalgia and sometimes with stress fracture of the lateral border of the foot or base of the fifth metatarsal or the fifth metatarsal shaft. Because as you can see, basically, this patient is loading the lateral border of the foot more than normal. So the one in black here is a normal foot loading. And as you can see, as we agreed before, heel and going from the lateral border up to the first mid head and the toes. And as you can see, there is no overloading or point loading in this normal pattern of weight bearing. While if the patient has a cavus, which is equal varus heel and plantar flexed first ray, the situation will be a very high point loading on the foot, which will be under the first metatarsal head, which will be under the fifth metatarsal head, and under the lateral border of the foot. That's why this patient very commonly to come with you with a pain in the lateral border of the foot because he's overloading the lateral border of the foot because of the deformity of ankle and hind foot. And sometimes they come with stress fracture. And very common clinical mistake is to deal with a stress fracture without correcting the main deformity. So the stress fracture happened before you because you're overloading this bone, not because of problem in the bone itself. So bone quality itself is okay, but because you are overloading this foot because of the deformity of your foot, you have a stress fracture. So the treatment of a stress fracture of a lateral border of the foot in a cavus foot is correction of cavus. This patient may come to with a history of instability. The problem of this patient, as you can see, the patient is, I'm sorry, we'll go back. The patient here is normally stretching the lateral structure of his foot. Normally he has an incompetence in the lateral ligaments. And on the other side, we understand now the problem of the musculature. So his E vertebras, which is pronator brevis, is weak. So pronator brevis is weak. He have a stretched lateral structure because of the varus position of the hind foot and the plantar flexion of the first ray. So he is commonly to have a giving way because there is the lateral strata of the ankle are weaker. At the same time, this patient, the commonest cause of it is neurology, as we agreed. And with the neurology, especially the sensory neurology and the motor neurology he have with Charcot-Marie-Tooth, this patient will be having a lateral instability because the muscles on the lateral aspect are weaker than the medial aspect. Definitely will be having a difficulty wearing shoes, and commonly you have this patient living life with insoles or an arch support, orthotic or insoles, because they cannot fit their shoes inside their foot in a normal shoes. When you see this patient, the first question you need to ask about, is it unilateral or bilateral deformity? And when did this deformity happen? And is it progressive or not? And does he have any associated problems or symptoms or not? Commonly, this patient, I'm sorry, if this patient has a unilateral deformity, mostly he will be having a spinal cord injury or some sort of injury or neurology from the spine. If this patient have a bilateral deformity, mostly he will have a generalized neurological problem, commonly the hereditary sensorineural neuropathy, sensory motor neuropathy, or Charcot-Marie-Tooth. You need to ask clearly about the neurological spine trauma and neurological symptoms, and you need to ask about the family history. How will you examine this patient? Same protocol as we agreed. First thing, to have a look around the patient. Have a look if he has using any aids or any walking aids or sticks. Have a look in the shoes. You need to have a look in the shoes. Ensure where is the point of wear in the sole of the shoes. You basically will see a lot of wearing on the lateral aspect of the shoes on the the sole of the shoes because the patient is overloading his lateral border of the foot. If patient starts to walk, you can easily spot that the patient has a high arch, high medial arch. And if this have a neurological background, this patient will be walking with a shuffling or high steppage gait because of the foot drop. You have to have a look on the hand, and very commonly with Charcot-Marie-Tooth to find guttering of the hand because of the atrophy of the muscle. And definitely you have to look on the spine to ensure there is no signs of spinal operation, there is no sign of spinal trauma, there is no clear aggressive deformity, there is no clear signs of dysraphism. While patient is standing, have a look from the back. You expecting to find this patient heel in varus. Have a look from the side. You expecting to find a high arched foot with a plantar flexed first ray, and you expecting this patient, if he has a neurological origin of the problem, to have a clawing of the toes. Definitely, while patient is standing at the same stage, do a Coleman block test. So both piece of wood or whatever you use, or whatever, a book or something, underneath the first ray, according to the idea we explained about the tripod. So this patient, the tripod, this is the first ray, has been blunt reflexed. So the whole thing for the whole thing to change, it has to go this way. So if you raise the first ray from the ground, you normally should see a corrected hindfoot varus. This is the standard Pes Cavus, which is forefoot driven. If this doesn't happen, means the hindfoot, either the hindfoot is the origin of the deformity, or the hindfoot become rigid and arthritic and it's not moving anymore. So Coleman block test will give you two results. Number one, correction of the heel varus on raising of the first ray, which equal is this deformity is driven from the forefoot and the hindfoot is supple. Or the other way around, even if you raise the first ray, the deformity of the hindfoot will not correct, and this gives me one of two meanings: either the deformity is hindfoot driven, not forefoot driven, or the deformity is forefoot driven, but the hindfoot become arthritic and it's not supple anymore. Once you sit your patient on the couch, have a look on the sole, and definitely you will be looking at the pressure areas, and you will see the pressure areas very clearly under the first ray and over the lateral border of the foot. You may find ulceration, especially if the patient is neuropathic by any mean, either spinal cord problem or trauma, or Charcot-Marie tooth. And this is because of the hyperkeratosis and overloading and over-attriation there, you find some ulceration. And once you correct the heel varus into normal, into neutral position, you will see clearly a pronation of the forefoot. So it's very important to comment on the forefoot position after correction of the heel. When you start to ask this patient to move, again, same system. Sorry. We'll do an active range of motion, then passive range of motion, and passive range of motion. And you need to comment on the deformity. Is this deformity is correctable or not? So is the hind foot is corrected into neutral? And if it's in neutral, is the forefoot pronation is correctable or not? You definitely, as we understand that the muscle imbalance is one of the main causes how the Pes Cavus happens, we need to comment on each tendon and how we examine, and we agreed on this before. We need to examine pronatus longus, tib ant, tib post, and pronatus brevis. You definitely need to do a thorough neurovascular examination, and cervical test is very positive to check if the patient has a tightness in the Achilles or a gastrocontraction. So what's the pathoanatomy behind the Pes Cavus? So as we agreed again, the idea of the tripod, so Pes Cavus starts by plantar flexed first ray, which is ended by pronated foot, and this pronated forefoot equal that to be corrected that the foot is plantar flexed and the hind foot is in varus. Causes of Cavus is a lot. Idiopathic is not an uncommon cause, is a common cause. Then you may have it congenital, like in patient with club foot or arthrogryposis. You may have it traumatic, as we agreed. If unilateral, it may happen from a crush injury in the back, from a compartment syndrome in the leg. It may be neuromuscular, and this is the commonest: Charcot-Marie tooth, spina bifida, polio, CP, ataxia, or stroke. If you have a look in the X-ray, I need you to understand that you cannot comment on an X-ray for Pes Cavus unless the patient is standing weight bearing, and your X-ray should be an EB lateral and oblique views. You will spot three angles, and you need to measure them correctly: is the Meres angle, Hep's angle, and the calcaneal pitch. So if you look in the Meres angle, this is the angle. So basically, it's between the longitudinal axis of the talus and the longitudinal axis of the first metatarsal, and normally it is 0 to 5. If it is more than 5, it is Pes Cavus. If it's less than 0 by minus, it is a Pes planus. Then Hep's angle is between the longitudinal axis of the calcaneal and the first metatarsal axis, and this is normally an obtuse angle, as you can see. And if this angle is going beyond 150, this means the patient is in Pes Cavus. Calcaneal pitch, basically, you're doing a tangential line here, this number 3, tangential line here, and the ground, and normally this is 16 to 32 degrees. If this calcaneal pitch is increasing, means, sorry, if this calcaneal pitch is increasing, this mostly in Cavus, and if it's low, it is in planus. So in this X-ray, you can spot these angles on an X-ray. So this is a tibio-talar angle. Ignore this one. This normally should be 90, but ignore it. This is the Meres angle. It's the longitudinal axis of the talus and the first metatarsal. This is the Hep's angle between the longitudinal axis of the calcaneum and the first metatarsal axis, and the calcaneal pitch. This one is not here. You can spot here very easily. Sorry. You can spot here what we call the kite angle. So the angle between the angle between the longitudinal axis of the talus and the calcaneum, and definitely with a cavus, this angle will be reduced. In this X-ray, you can easily spot the uncoverage of the talonavicular joint, and as you can see, this longitudinal axis of the head of the talus, and this is the articular surface of the navicular, and you need to spot this clearly to see if the patient, how much uncoverage of the talus is there. This is not a perfect Saltman's view, but it gives you an idea where is the position of the hind foot, and you can easily spot that the hind foot is inverse. And if you look on this X-ray, you can easily spot that this is the longitudinal axis of the talus, and normally it should be running with the same longitudinal axis of the foot, which is going through the second metatarsal. But as you can see, because of the cavus, the forefoot is adducting, and because the forefoot is adducting, the heel isn't going into varus. You need an MRI scan if your deformity is unilateral, because the risk of having a spine problem, either injury or dystrophism or compression or whatever is there, you have to have an MRI scan of the spine. When you ask in the exam about the management of Pes Cavus, we all again agreed that it is neurological until proven otherwise. So you need to have an MDT approach. You have to involve the podiatrist. You have to involve the neurologist. Very, very important. Don't touch this patient, even if you are sure that it is an idiopathic cavus, unless you get a neurologist opinion which says that it is idiopathic. Definitely, as any treatment, we have to start with non-operative. So non-operative for Pes Cavus will be show wear modification, will be some orthotics and insoles. Either this is still a supple hind foot, so we use an corrective orthosis, or it is become rigid, and we need to use an accommodative orthotics. Neurological treatment under the neurologist, they need to have a very good go with the neurologist until they get proper management. What if I operate on a Pes Cavus and the non-operative treatment is not enough for the patient? So we have few principles you need to understand this by heart. Number one is the Koch law of how to correct a foot deformity, and this applies to all foot deformities, especially cavus. Firstly, number one, you need to get the heel underneath the cuff, so you need the heel under the tibia. You need to have the foot plantigrade, and to do the heel under the tibia, you have to do one of two. Either number one, lengthening of tendo Achilles, or a shifting calcaneal or displacing calcaneal osteotomy, lateral calcaneal osteotomy displacement. To have the foot square on the ground, you have either to dorsiflex the first ray, osteotomy, release of the plantar fascia. Then you have to have a balanced muscle to overcome the reason that, or the cause, or the anatomy behind the Pes Cavus. And this balance equal that you need to move one of the inverters to become an everter, so you can transfer the tibialis posterior to the dorsum of the foot, and you can get the peroneus longus to be transferred to the peroneus brevis to give it some eversion power. If your foot is still flexible, definitely you will do a forefoot surgery to treat the driving cause. And if the varus is fixed, so you don't have any option to correct anymore, and the option here will be a combined forefoot and hindfoot surgery, and mostly will be a fusion or arthrodesis. You have, after the Koch law, you have the role of toes. So you have two soft tissue to release, tendo Achilles, which is tight, and plantar fascia. A lot of debates about the plantar fascia release. Many centers at the moment doesn't do a plantar fascia release, but the classic teaching is still you have to release the tendo Achilles and plantar fascia to get the cavus sorted. You have two tendon transfers to do. And again, as I told you, you move peroneus longus to brevis to give the more eversion force and allow the peroneus brevis to balance the tip post. Otherwise, is to get the inverter weaker, or to weaken the inverter by moving the tip post from a position of inversion to a dorsum of the foot to be weaker inversion, and to balance the weak peroneus brevis. Osteotomies, if you will do, you have two osteotomies to do, either lateral displacing osteotomy of the calcaneum to correct the heel varus, or first MT or cuneiform dorsiflexing osteotomy to correct the plantar flexion of the first ray. And definitely in the severe or rigid cases, the option you have is to have a hindfoot corrective fusion or treble fusion. So you have, as I told you, you will have a clawing of the toes, and the clawing of the toes has two reasons. Number one, the same pathology which caused the Pes Cavus, which is a neurological cause, and the other one is trying of the foot to overcome the weak inverters. I'm sorry, the weak everters and plantar flexors, dorsiflexors. So what's happened? The first ray is plantar flexed, and the plantar flexors of the dorsiflexors of the foot are so weak, which is the tib ant. So the patient start to recruit the AHL or the extensor hallucis longus to do the job of the tibialis anterior. I will go in a minute in the muscle imbalance in the Charcot-Marie-Tooth, but to understand, we in the first lecture we agreed that we have counteracting muscles on both sides of the ankle. So tib ant is overcome by the peroneus longus. Tib ant is elevating the first ray, and peroneus longus is dropping the first ray. Tib ant is dorsiflexing the first ray, while peroneus longus is plantar flexing the first ray. On the other side, you have peroneus brevis versus tib post. Peroneus brevis is an everter, and tib post is an inverter. In the Pes Cavus, especially if the Charcot-Marie-Tooth is the cause, the tib post is stronger or overpowering the peroneus brevis, and the peroneus longus is overpowering the tib ant. So you have a weak tib ant and a weak peroneus brevis. Weak tib ant, so no dorsiflexion of the first ray, that's why the first ray drop or plantar flex, and weak peroneus brevis, so no eversion, so the inverter are more stronger, that's why the heel goes into varus. Again, you have counteracting muscles maintaining your ankle and foot balanced. Tib post and peroneus brevis. Tib post is an inverter, peroneus brevis is an everter. In Charcot-Marie-Tooth and Pes Cavus, tib post is stronger than the peroneus brevis. Tib post is causing the heel to go into varus and the forefoot to go into adductus. While the peroneus brevis is weak, that's why the eversion is weak. The other group of muscle counteracting muscles is the tib ant, which is normally dorsiflexing the first ray, and the peroneus longus, which normally plantar flexing the first ray. In Charcot-Marie-Tooth or Pes Cavus, your peroneus longus is stronger or overpowering the tib ant. So the plantar flexing force on the first ray is stronger than dorsiflex. That's why the first ray goes into plantar flexion. For the patient to compensate for the weak tib ant or the dorsiflexors of the ankle, because your tib ant is the main dorsiflexor of your ankle. Because tib ant is weak, the patient, to overcome this weakness of the tib ant or the ankle dorsiflexion, he recruit the EHL, the extensor hallucis longus, to do the job of the tibialis anterior. And with time, the extensor hallucis longus is over-recruited. It starts to cause a clawing of the first of the hallux or the great toe. That is one of the causes why the hallux go in clawing with a Pes Cavus. To treat this surgically, the option you have is to do what's called John's procedure. And it's basically, as you can see here, we fuse the IB joint. So get the IB joint, insert a wire through, and get the AHL, detach the AHL from here, and move it around the first metatarsal neck. So it's doing the job of dorsiflexing rather than plantar flexing, and there is no more movement in the IB joint. So John's procedure basically is fusion of the IB joint of the great toe and moving the AHL to hook around the neck of the first metatarsal. So doing the dorsiflexing action of the first metatarsal without any clawing because of the fused IB joint. If you have clawing of the lesser toes, the option you have is to release the flexors, so do flexor tenotomy, or to fuse the IB joint, or even to excise them. So if we come to the commonest cause of Pes Cavus, which is Charcot-Marie-Tooth, it's basically, in simple terms, it's a demyelination of the nerves of the peripheral nervous system. That's why it gives an hereditary, so HSMN means hereditary sensory-motor neuropathy. Hereditary sensory motor neuropathy means because if there is demyelination or problem of the myelin sheath of your peripheral nerve, so your sensory and motor nerves are dysfunctioned. It is a very common cause in bilateral cavus feet. It's a type of an autosomal dominant problem, and it's most commonly aggressive inherited neurological disease if you have it. It's always present in the second decade of life, and it's a bit progressive. It's not uncommon, to be honest. There are two types. The most progressive is type 1, when the demyelination and patient have a cavus and second decade, and the type 2 is a bit less aggressive with some Valerian degeneration, and it's always the late onset, and the patient will be on the flaccid side rather than the spastic side. Now we'll go in the same pathology I explained from a minute ago, is about the affected muscle. So basically what Charcot-Marie-Tooth does, it makes some muscles weak and other muscles stronger, so it imbalances the muscles around the foot and ankle. And as we agreed, the peroneus brevis is and tibialis anterior will be weaker, and the tib post and peroneus longus will be stronger. And when you see that the same happen with the intrinsic muscles of the hand and feet, and that's why you have to examine the hand, because you will see the guttering in the web spaces. Cavus happens because, as we agreed, peroneus longus, which is a plantar flexor of the first ray, overpower the tibialis anterior, which is a dorsiflexor of the first ray. And varus happen because the tibialis posterior, which is normally an inverter, overpowering the peroneus brevis, which is normally an everter. The hammer 2 happen because weak ankle flexors recruit the two extensors that, as we agreed, and the other cause of claw 2 is under Charcot-Marie-Tooth specifically will be a weak intrinsic muscles of the foot. Charcot-Marie-Tooth has a common association as a neurological problem with hip dysplasia, because you understand that for a normal hip to develop, it has to have a normal muscle action around it. Because the muscles are imbalanced, the hip dysplasia is very common association with Charcot-Marie-Tooth. And the same cause you will have an aggressive severe muscular scoliosis, which mostly will be a left curve, which is an atypical curve, and will be thoracic curve and maybe kyphotic. As an investigation, you have X-rays, and we agreed about the X-rays on a Pes Cavus. Charcot-Marie-Tooth at the end of the day is a bilateral Pes Cavus condition, so the X-rays will be the same. You may have, because we understand that the Charcot-Marie-Tooth cause cavus because of muscle imbalance, we may do an EMG, and definitely because it's an autosomal dominant inheritance, we may do a genetic testing for the patient. MRI scan or spine, if you have a unilateral deformity, this is to exclude the spine causes. And definitely the treatment of Charcot-Marie-Tooth, as we agreed for Pes Cavus treatment, is an MDT. You have to have a neurologist, podiatrist, at the end of the queue is the orthopedic surgeon. Because the treatment of Charcot-Marie-Tooth is basically non-operative until proven otherwise. And non-operative, again, the same treatment will be footwear modification, will be insoles, and the insoles will be added, because this is definitely an accommodative one, will be a rigid insole with depression of first ray and lateral wedge underneath the heel. If you will operate, same story. All what we aim for is to achieve a plantar grade, stable, showable foot. And depending on the deformity, every deformity will be corrected. Same story as we agreed on the Pes Cavus, nothing new. There is some uncommon Pes Cavus deformities, and I need you to have a look on this X-ray. And this picture, and to keep it in mind and keep your eye memory remembering every definition of this. So the classic one is the Pes Cavovirus. This is the one we've spoken about the whole lecture. Then you may have a Pes Equino-Cavovirus, and equino means the calcaneal pitch is low, means that the foot is in plantar flexion with a cavus. So plantar flexion at the ankle and cavus at the midfoot. And Pes calcaneo-cavus, as you can see, so the calcaneum, again, means the calcaneal pitch is very high. The calcaneum is dorsiflexed, and the foot is and the forefoot is plantar flexed, and this will have the highest arch. Then there is Pes valgocavus, and basically this is about the position of the hind foot. So the hind foot, rather than being in varus, will be in valgus, while still the midfoot is in plantar flexion. So another two uncommon deformities, and we'll quickly go through them, is equinovarus and equinovalgus foot. So equinovarus foot, the commonest to have it is a residual from the talibus correction. So if you don't correct your talibus completely, you will end by residual clubfoot deformity or equinovarus. And basically, this patient will be walking on the lateral border of the foot, as you can see in this clinical picture. Other causes, which is a bit rare causes, is cerebral palsy if the patient has a muscular dystrophy, spina bifida, or hemimelia. Commonly with the tibial hemimelia, the patient has has lost medial structures. That's why normally the foot goes into varus. Following a stroke, definitely, because following a stroke, the muscle imbalancing and the deformity will be an equinovarus. Again, varus is tibialis posterior overpower, and equinus is gastrosoleus complex overpower. Treatment, if it's a residual clubfoot deformity, so you will do the same, again, serial casting by Bonsetti technique and ankle foot orthosis. You may need, if there is a cerebral palsy, especially a spastic cerebral palsy, you need some Botox injection to relax the muscles which is overcontracted, like the tib post and the gastrocnemius. Definitely, you need some physiotherapy, and if you fail in all of this, you need to lengthen the Achilles, and you need to do a split transfer of the tibialis anterior, and even do a split tendon of the tibialis posterior. In more advanced cases, you may need to do a calcaneal osteotomy, and if the patient is rigid deformity, you may need to fuse. Other way around is the equino-valgus foot, and again, valgus equino, the same, is because of the spasticity of the gastrosoleus complex, and valgus is because of overpower of the peroneus brevis. The hind foot will be in equinus, and it will be benfic callosity over the talar head on the medial aspect of the foot. Commonest cause of this is lost lateral structure of the ankle in fibular hemimelia and cerebral palsy. In the fibular hemimelia, the ankle is called ball and socket ankle, and it lost fibula. There is no fibula. Fibular hemimelia means there is no distal fibula there. With a ball and socket ankle, easy for the ankle to go in valgus and equinus. Treatment, again, the same. You will be doing some physiotherapy, doing bracing, Botox, Achilles lensing, and peroneus brevis lensing if non-operative measures do fail. And at the end, either calcaneal osteotomy, and if it's a rigid deformity, will be a subtalar arthrodesis. The second topic in this lecture will be the rheumatoid foot. And rheumatoid foot is an exact picture of a rheumatoid hand. Rheumatoid is a systematic inflammatory disease with a polyarthralgia everywhere. The pathology is studied in the synovium, and all of you are much better than me in understanding the pathology or the pathology cascade behind the rheumatoid. The rheumatoid hand, the rheumatoid foot are the same. Same in diagnosis, same in pathology, and same in treatment. So with the rheumatoid foot, you can see the forefoot, as you definitely spot there is a hallux valgus, and always there. Most of the time, clinically, is not symptomatic, and this is not the main complaint of the patient. The patient have polyarthralgia and joint pain. His biggest problem is in the bunion or the hallux valgus. Definitely in X-ray, you will see an erosive arthroplasty, and this erosive arthroplasty will be very articular because the problem starts in the synovium. You will have, after some time of the synovitis and destructive process in the joint, the MTB joint will be dorsally subluxing. There is no more fat pad there, and definitely you agree with any rheumatoid disease. The soft tissue are very weak, and one of the weakest structure because of the rheumatoid is the plantar plate. And once the plantar plate goes, the joint is the dorsally sublux. When the MTB joint dorsally sublux, you'll definitely see the metatarsal head very prominent. And because it's prominent, it will be a point loading, will be some callosity and plantar tenderness there. Because the plantar plate has gone, the main strut to stop the hyperextension of the MTB joint has gone. MTB joint will go in hyperextension, and the flexor tendon will still be empowering, and that's why you will see hammer toes or even claw toes. So again, problem is in synovium, polyarthralgia, polyarthritis, inflammatory arthropathy, which is erosive arthropathy. With the time, it starts to cause joint arthritis and at the same time soft tissue destruction. And as you understand, definitely that rheumatoid is a very destructive inflammatory condition, especially for soft tissue. The earliest soft tissue to get damaged is the plantar plates, and once the plantar plate is gone, the MTB joints in the lesser toes dorsiflex and dislocate dorsally, and that's why you feel the metatarsal head are prominent, and there is some callosity and plantar tenderness underneath it. Because the MTB joint lost the main strut against or main resistance against extension, the MTB will go in an extension because plantar plate has been damaged, and this is a time when the flexor tendon will cause a hammer and claw toe. In the hind foot, you can see a valgus. You will see a valgus ankle because valgus ankle, because basically the spring ligament, the plantar fascia has gone. Because the spring ligament and plantar fascia has gone, and again and again and again, rheumatoid foot is a soft tissue problem before bony problem. The foot will go into, as you see, a severe valgus heel, a widespread osteoarthritis. I'm sorry, it's not osteo, it's a widespread arthritis, and with severe abduction of the forefoot and valgus of the heel. There definitely will be tenonavicular uncoverage up to tenonavicular subluxation, and there is no question that this patient will have a subfibular impingement. So again, in the hind foot, the main problem is a problem of soft tissue. Your spring ligament, your plantar fascia is very weak, and this is the time the heel will go into valgus and the arch will be flat, and definitely this will be going aggressively, added with the arthritis in the joint, in by tenonavicular subluxation, prominence of the talar head and loading on the talar head, and definitely subfibular impingement. Again, the soft tissue, so tenosynovitis of tib post and perenniae, you will have a collapse of medial arch because tib post rupturing or spring ligament rupturing or tenonavicular subluxation. You will definitely have a tarsal tunnel syndrome, which is compression of the tibial nerve underneath the flexor retinaculum. And Morton's neuroma is very common as any soft tissue problem. And retrocalcaneal bursitis, you can spot here how big and how aggressive are the bursitis. Examination of the rheumatoid foot as examination of the rheumatoid hand is examination of the whole patient. Rheumatoid is a systematic disease. It's not a local disease. Even if it's expressed itself on the foot or the hand, you have to examine patient head to toe. You definitely have to assess the hip, assess the knee, assess any proximal deformity, because your plan of management will depend on what deformities do you have, starting with proximal deformities before distal deformities. You have to assess the skin, you have to assess the tendons, you have to assess the vascular condition, you have to assess the neurological condition, and you have to have your investigation, including X-ray, MRI scan, and CT. Management, no question, MDT, MDT, MDT. An MDT start with a rheumatologist. You cannot touch a rheumatoid patient without very good medical care and very good medical control of his rheumatology, rheumatoid. And thankfully to the new disease-modifying drugs and the biological treatment, which end by a lot of rheumatoid patient medically cured without need for any surgery. So rheumatoid patient is a medical patient until proven otherwise. You never touch the rheumatoid patient with knife unless you have exhausted all the medical measures of controlling the rheumatoid. So rheumatologist, your MDT will be a rheumatologist, will be a physiotherapist, will be orthotics, and non-operative as any foot and ankle condition, foot wear modification, non-steroidal, steroids, disease-modifying agents, and biological treatment, and definitely some targeting steroid injection and some accommodative orthotics. If no option and the patient is medically controlled but still in a lot of pain because of the abnormal foot shape and abnormal foot position, this is the time you will do the surgery. And your surgery here, you need to understand there is no soft tissue to depend on. And your surgery aiming to have a pain-free, plantigrade, showable foot, not a normal foot. The rheumatological foot will never be normal, but you need to have a pain-free, plantigrade, and showable foot. So for the first MTB, definitely because there is no dependence in the soft tissue, there is no space for any realignment surgery or scarf osteotomies or whatever. The room here is only for first MTB fusion. If you want to straighten the lesser toes, so you have either to do a vials, to do a shortening osteotomy of the MTB of the metatarsals, or to do a stents B procedure, which is an excision arthroplasty or of the lesser MTB joints. In the hind foot, the gold standard is to fuse it, so ankle arthrodesis. It's evolving evidence to support TAR or total ankle replacement. To be honest, in our hands, total ankle replacement is doing a great job in rheumatoid, and it can easily overcome the arthrodesis. And now the total ankle replacement is the treatment of choice in rheumatoid foot. And definitely we cannot ignore the TARVA trial, which is a UK multi-centric pragmatic trial comparing ankle arthrodesis versus ankle replacement. And it has involved the rheumatoid patient. You need to go and read the TARVA trial, and we'll give you an insight that the ankle replacement is a good and a valid option to ankle arthrodesis. The third and the most important part of this lecture is the diabetic foot. And you need to understand that our problem of the diabetic foot is it's a neuropathic foot. Definitely, this is we look in the diabetic foot to what concerns us. So if the patient have an uncontrolled hyperglycemia, so he will have a neuropathic foot, and this neuropathy in the foot will end by two theories to explain destruction in the foot. So the first, to understand the pathophysiology in the diabetic foot, you need to understand that the first neurological abnormality will be loss of vibration and position. And with loss of vibration and position, there is no more protection. And with no more protection, the result will be abnormal loading and abnormal pressure areas. At the same time, you have an autonomic dysfunction. And because of this autonomic dysfunction, the skin will be dry, will be cracking, and easily ulcerating. There will be another a motor dysfunction, and with the motor dysfunction, the muscles are imbalanced between extrinsic and intrinsic, and this is end by a claw and hammer deformities, which may add to the pressure points. So the first and the main problem for us in a diabetic foot is the neuropathy, and the neuropathy is sensory neuropathy, autonomic neuropathy, and motor neuropathy. Sensory neuropathy end by loss of protective sensation, starting with vibration and position, then loss of a protective sensation to tactile sensation and pain, and this end by pressure areas, insensate ulcers, and foot injury, foot problems. Autonomic dysfunction, which end by dry skin, which easily cracks and ulcerates. Motor dysfunction, which end by muscle imbalance, and with the muscle imbalance, you will definitely have some deformities of the foot and toes. On the other hand, other than the neurology, is the vascular side, and we definitely agree that the diabetic patient has a vasculopathy and atherosclerosis. And with the vasculopathy, the healing will be very poor, and the soft tissue will be in a poor condition, and this is a very good media for infection. At the same time, systematically, the diabetic patient has a low immunity, high risk of infection, and always this infection is polymicrobial or mixed. If the patient has diabetic foot ulcer, this ulcer will be hyperkeratotic, will be pink, bunched out base, will mostly be painless because the patient is neuropathic, and will be bleeding because there is no normal contraction, or vasoconstriction in his vessels. And this you can I'll put it in a separate slide because you need to spot easily that the patient has a diabetic foot ulcer. This is very, very important. And as you can see, and as we understand, it's a pressure point under the first metatarsal head. And you can see the hyperkeratotic is pink, is punched out. As you can see, this ulcer bed is nearly okay, but it's commonly to come to you with infection and bleeding. So if you want to investigate a diabetic foot patient, again, you need to look in the systematic problem. So you need to have HbA1c and to be ensured that this is not beyond 7. If HbA1c above 7, this means uncontrolled, and there is no option to treat this patient until you get your blood sugar controlled. Definitely, this patient will be having a hypoalbuminemia and hypoproteinemia, and this is affecting the wound healing. And you don't want to operate on a patient with a poor healing or poor wound healing power. So you need to be ensuring that your albumin is above 30 grams. Total lymphocytic count with TLC will be definitely high because the patient will have some sort of infection, even if a low-grade infection. The important and the gold standard to assess the wound healing is to have a look in the transcutaneous oxygen pressure, which gives you an idea about the healing potential of this patient. And you need this transcutaneous oxygen pressure to be above 30 millimeter mercury to be sure that your wounds will be having a good healing potential. Ankle brachial index is pressure index is very, very important because one of the earliest signs to show to you that this patient has a vasculopathy and has a poor blood supply to the lower limb. If your ankle brachial pressure index is below 0.45, this means that the vascularity to the lower limb is weak or insufficient. And with vascular insufficiency, you don't wait for an ulcer to heal. So you have to have a vascular surgeon in your team. X-ray to show osteomyelitis and Charcot arthropathy or destruction, and definitely X-ray isn't the best investigation to show osteomyelitis. The leukocytic scan is very, very sensitive to infection. It can basically give you a positive hotspot if the patient have an osteomyelitis or infection, and will be negative if just a neuropathic joint or a Charcot joint. MRI scan is very important, but has its own limitation because you will see a bone edema and you cannot differentiate is this edema because of Charcot destruction or because of infection. Definitely, deep tissue biopsy will give you an idea about a specific bacterial infection and a specific sensitivity antibiotic, and this will give you a better option to treat this infection. Diabetic foot is in a certain speciality problem. It is a diabetic foot, so it is an MDT. NICE guidelines in 2019 stated that an MDT approach should have a diabetologist to control the blood sugar, a podiatrist to look after the foot, diabetic specialist nurse to action the podiatrist advice, orthotist, vascular surgeon, microbiologist, radiologist, plaster technician, and TVN, which is tissue viability nurse, and definitely orthopedics. And plastics in some big centers, plastics is part of the team, and in smaller center, plastics will be available for advice and management. So we have this in my diabetic foot team. So my diabetic foot team has a diabetologist, has a podiatrist, has a diabetic specialist nurse, have plaster technician, have a vascular surgeon, have a microbiologist, has a radiologist, and we TVN, and we definitely have an access to plastics. And thankfully, our team has been awarded a national award from the King because we get the rate of amputation below 70% in the area, which is a major achievement. And I can promise you, this is one of the best service you can offer your patient. We have a dedicated ward for diabetic foot. We have a dedicated ward round every week. We have a dedicated MDT clinic every week. And the service is marvelous. When you see a diabetic foot, you need to examine the patient for risk factors. And we agreed from the previous slide that the risk factor will be neuropathy, vasculopathy or limb ischemia, ulceration, callus, infection, deformity, gangrene, and Charcot arthropathy. From these risk factors, you will do what's called risk stratification and know where your patient is both on these degrees. Is it a low risk patient, is a moderate risk patient, or a severe risk or a high risk patient? Low risk patient basically doesn't have any of these risk factors, maybe minimal or early Charcot and minimal callus. And this patient, all what's needed is annual foot assessment. You ask the patient to keep an eye on his foot. You look on after the patient once a year just to ensure that everything is going in the right way. Moderate risk, this is the patient who should start to have early neuropathy and mild deformity. Still, the patient have intact sensation, just neuropathic, but not badly neuropathic or insensate. And the deformity hasn't changed the shape of the foot and is not causing a pressure point. And in this case, you have to get this patient under the foot protection service and to see within 6 weeks and to do a 3 to 6 months regular assessment. If your patient is high risk, this is when the patient have a previous ulceration, previous amputation, have a renal replacement, have a critical limb ischemia, have a neuropathy, have a combination of any of this. And this patient need to be under the foot protection service within 2 to 4 weeks very urgently. And this patient have to be seen in the clinic 4 to 6 weeks, every 4 to 6 weeks. The principles, if you're treating a diabetic foot, definitely, again, you're treating the cause firstly. You have to strictly control the diabetes. And this is the rule of the diabetologist. You have to have a very good patient education because it is a multidisciplinary approach, including the patient in the center of it. It's a patient-centered approach or patient-centered treatment. You have to optimize your foot. Offloading is a magic word. So your foot has to be offloaded. You don't accept or allow any pressure points in the foot. Infection has to be treated either medically if it's still under control or surgically if the medical or antibiotics fail to control it. Antibiotic has to be under microbiologist advice and to be as much specific as possible and sensitive as possible. Limb ischemia is very important, and if you have a limb ischemia, either you get a vascular surgeon or an intervention radiologist on board, and they have to do bypass or to do angioplasty or whatever to get the limb vascularity back to normal. Wound debridement and dressing is definitely if you have a wound debridement. Treating the ulcer will be an aggressive debridement, and we'll go to this in details in a minute. And definitely, if you're doing something bony, so your bony either will be a very rigid internal fixation or an arthrodesis. The goal of treatment of the diabetic foot is number one, I'm speaking about the surgical goal. The surgical goal is to reduce the deformity, so avoid any bony prominence or pressure point. Have your foot showable and blunt grade. Provide some stability so you don't have any instability in the hind foot or the ankle, and definitely prevent ulceration by proper offloading and protective braces and insoles. If you're going to debride the infection, your debridement is very specific. It shouldn't be done by a general orthopedic surgeon. It should be done by a diabetic foot surgeon. And if you don't have a diabetic foot surgeon in your unit, it's much better to be done by the plastics, because they normally do an aggressive debridement over the orthopedics, general orthopedics. So if I will debride, I'll be very aggressive. I will not leave any doubtful tissue. We all understand the zones of the tissue. So even zone 1, which is still doesn't show clear changes, I will be debriding this. I must end by a very nice, clean, pink, bloody points. Other than this, I will not trust any tissue, and I will remove everything. The more you remove, the more you save the patient. You have to keep your wound open because it has to express itself if there is any infection or anything. And you can use a negative suction pressure. Definitely, the negative suction pressure induce granulation, minimize the soft tissue, dead space, and get any debris or infection away. Antibiotic. So you have a nice guidelines for diabetic foot problems 2019. You can start with empiric antibiotic, but you have to go for a specific antibiotic based on a deep tissue sample and microbiologist advice. Wound care is definitely offloading ulcers and avoid barrier to infection and absorb exudate. To do an offloading, which is very, very important, so you have 2 options. The option is total contact cast or the rock or bottom offloading shoes. Both options are in front of you in the pictures. So the total contact basically is just accommodative to offload the foot. We keep it there for good 4 to 6 weeks during the patient is during in the acute stage, but we have a look on it weekly. So it have to be changed weekly because this foot is very dynamic. Swelling will be reduced. The foot will be losing the side the cast, and the cast is not doing the job. The cast to be doing the job has to be covering the whole foot, doesn't allow any pressure point, and distributing the pressure simultaneously and at the same degree on all portions of the foot. It's definitely to be non-removable because you will have a big problem if you're dealing with diabetic feet about patient compliance. What are the surgical principles if I'm treating a diabetic foot? So to start with any diabetic foot, you have to release the tendo Achilles. Tendo Achilles is definitely tight, and you don't want this patient to be overloading the forefoot and causing pressure points there. Any pressure point has to be removed. So you have to shave any bony prominence. You have to keep this foot absolutely blunt grade, no pressure points. If you be doing a bony procedure, you have to be very aggressive in fixation. So if you normally treat a Weber B ankle fracture in a cast, for a diabetic, you have to fix it. If you're fixing a bimal ankle fracture with a blade and screw laterally and a screws medially, you have to add syndesmotic screws for the diabetic. So diabetic should have double the amount of metal as a normal patient. So you have to be very, very aggressive. If you're going to reconstruct, you have the options of plates or beams in the midfoot, and you have the option of hindfoot nail if you're doing a hindfoot reconstruction. And if you fail in all this and you're unlucky and the patient is lacking luck, so amputation will be the answer. So to finish with the Charcot joint or the neuropathic arthropathy. So to understand Charcot is not diabetic. It's not with diabetes only. Charcot is with any neuropathic condition. So any neuropathic condition can end by a non-infectious destructive process, which we call Charcot, which end by a deformed joint or even dislocated. Charcot can happen with any cause of neuropathy. On top of them is the diabetic because it's the most common cause. Sorry. The whole neural axis should be examined. The patient may have a stroke, may have a spinal cord injury, may have he's chronic alcoholic, has meningomyelocele, has syringomyelia, whatever. Syringomyelia is the commonest cause of Charcot arthropathy in the shoulder or upper limb. The pathophysiology behind Charcot is 2 theories, neurovascular theory and neurotraumatic theory. So the neurovascular theory, basically, because of the nerve damage, the patient has increased local vascularity. Increased local vascularity end by hyperemia, bone hyperemia, and bone weaknesses, and this is stimulate the osteoclast activity, and this makes the bone weaker, so easily to deform. The neurotraumatic theory, in simple terms, the patient has lost the protective mechanism. It's easy to have a minor trauma to the foot, and minor trauma or minor fracture end by activation of pro-inflammatory cytokines, and this causes more destruction to the tissue. And because the patient has abnormal remodeling, rather than the bone remodel in a normal situation, it ends by a deformed and degenerated joint. As you can see, so we have grades of Charcot according to our stage of Charcot according to the X-ray. So basically, from a mild deformity, just hyperemia and osteopenia, this is the first stage. Then after that, you start to lose the bone architecture. You see the X-ray and you can spot there's something wrong going on. You cannot spot clearly what is the problem. Stage after that is it start the joint to sublux and dislocate, and this is an end by a completely sclerotic deformed joint. Differential diagnosis to this is definitely infection, gout, and cellulitis. So if you have a Charcot joint, the foot is active, the foot is hot, swollen, tender, deformed. How to differentiate it between being a septic joint or an osteomyelitis and a Charcot? So clinically, very simply, if you elevate the limb, so you're decreasing the vascularity. So if we depend on the neurovascular theory, so the increased vascularity will be less by independency of the limb, and this is should normally improve the edema in the Charcot. But if the patient has an infection, and because of the infection and inflammatory mediators, there is a local vasodilatation, whatever you elevate the limb, the edema will not reduce. So to differentiate clinically between a Charcot and an active infection, elevate the limb for 5 to 10 minutes, and normally with a Charcot you will find some improvement in the edema, but in the infection there will be no improvement. If you go to the lab, definitely the markers will be high in both of them, but the markers in infection will be shorting, so the very high numbers, but in the Charcot will not be that. MRI scan, as we agreed, this is if it shows a clear collection of pus, this is clearly sepsis, but it has a low sensitivity to differentiate between Charcot and sepsis because both of them will be having a bone signal. Bone scan, especially the leukocytic scan or the white BC's labeled scan, is very, very specific to identify infection and by hot spots or positive. And this is a very good one to differentiate between Charcot and septic. Definitely, bone biopsy will show us if there is a bacteria infection or not. Don't spend a lot of time on the classification of Charcot. You need to understand that Brodowski has classified it according to where the Charcot is. The commonest or type 1 to have a midfoot Charcot. Then type 2 to have a triple joint, which is talonavicular, calcaneal, cuboid, and subtalar. Then type 3 is inside the ankle, and either it's getting the ankle only or ankle and the calcaneal tuberosity. And number 4 is combination of this. And number 5 or stage 5 if you go to the forefoot. Brodowski is just as I told you, it's just a descriptive classification. And without Brodowski, you still understand and you still can spot where is the deformity is and what you need to correct. So how you assess a Charcot joint? Patient will come to you diabetic, neuropathic, may have a history of minimal trauma, and this is not uncommon. It's commonly to come to say to you that I have minimal injury, mild ankle sprain, something like that. Then since that, I start to see, because the patient is neuropathic, there is not a lot about the pain. But the history will be more about the deformity and the changing shape of the foot. And by changing the foot shape, the patient will not be able to fit the normal shoes in. The patient have some difficulty walking. When you examine this patient, you can easily spot the hot foot. The foot is a swollen, tender, red, and there is a deformity going on. Patient is standing, you can see the foot in abnormal or deformed position. One specific clinical test is to test the temperature gradient at different points of the foot, and if you see more than 2 degrees difference between the suspected Charcot limb and the normal limb, this is definitely an active Charcot limb. Stability is a very important point. You need to spot if there is any instability in the midfoot or the hindfoot, because this will dictate your treatment later on. If you plan to manage the Charcot, so your management according to the stage of the Charcot. If the Charcot is very early, all what you need is to stop inflammation and maintain the foot in normal shape, doesn't allow the foot to deform. You can do this basically by relieving pain, non-steroidals, There is some evidence about bisphosphonate, but the most important is either total contact cast or a rocker bottom shoes to maintain the shape of the foot. Total contact cast or total contact boot to maintain the shape of the foot and doesn't allow the foot to deform and go from stage 1 or 2 to 3 or 4. So main treatment is immobilization in the acute stage to avoid ulceration and to avoid allowing the foot to deform. This is the shape of the total contact boot and definitely the total contact cast we have seen before. If, as we agreed, as I told you, the evidence start to support, because as I told you that the pathology starts from the osteoclast abnormal activity. So some advocate bisphosphonate infusion over 12 months and suppose that this is improved pain and bone turnover, but this is not a nice advice or a nice guidelines. If you done this and you pass from stage 2 up to stage 3 and 4, so the foot is already deformed, so the option to have is to surgically correct it to a plantigrade chewable foot with no prominence. So excise any bony prominence or exostosis. If the foot starts to be deformed, you need to correct the deformity. You can shorten the foot, you can remove any deformed joints, and you can start to arthrodese in a functional position. This foot will not be normal again, but we can make it plantigrade chewable without any pressure points, and this is the main important point. You need to understand and educate your patient that you're dealing with abnormal soft tissue quality, abnormal bone quality, high risk of infection, generally unwell patient. So quality of the bone will dictate fixation. Very, very common to have fixation failure, very, very common to have reconstruction failure, very, very common to have infection or infected implant, very, very common to need a second stage or even a third stage or a revision surgery. And if all this fail, amputation is an option on the table. You cannot ignore that. If you can reduce the amputation rate, as I told you, by a good degree, so we reach 70-degree reduction in amputation rate, you will be granted a national award, and this will be a great achievement. You will be very proud of yourself. Charcot and diabetic foot is, I know it's not the most exciting speciality, but to be honest, when you see a patient, a saved limb or a saved patient, you'll be very, very happy and proud of yourself. And it's one of the obscure areas of practice in the UK and all over the world. Diabetic foot management is not a surgeon management, it is a MDT management. If you don't have a proper MDT, even if you are the best surgeon, results will not be the greatest. But if you have a proper team, even your surgical skills is not the greatest, you will have a very good results and you will achieve what you aim for. Thank you so much. So good, yeah, on time.
Thank you, Mr. Hasham.
Guys, questions. Yeah, use it as much as you can. Try to get all the questions, and I'll be more than happy to answer it. Any questions, guys? So, since no questions, so basically, yeah, I've applied already for College of Surgeon accreditation for the course. I should be receiving the decision by the early Jan or the early New Year. Keep feedbacking, so you will receive a feedback form from mid-all. Fill the feedback form and you will receive your certificate. Next month certificates will be Royal College of Surgeons accredited, hopefully. I hope I'm trying to concise it to make it an hour 15 maximum, just to get everything on board and understand everything. And we'll keep it like that. I make it in 10 lectures, so this is the third one, so we still have 7. We'll be doing it every Friday at the same time as we agreed. Will be an hour, not more than this, just to give you a chance to understand and digest every information. Again, my mobile number and my email, if you got any question to ask. The video record about this will be kept on the mid-all, and will be on the YouTube channels. I announced it at the early in the lecture. Ahmed is asking, management of Weber B ankle fracture in diabetic should be aggressively fixed or simply as hindfoot nail. So Ahmed, if Weber B, so basically is an aggressive fixation. If you agree on a conservative treatment for Weber B in a normal patient, you shouldn't be agreeing on that on a diabetic. Your fixation should be very aggressive. You should be getting as much fixation, as much metal as you can to maintain everything stable. Remember, this patient have a poor quality bone, poor quality soft tissue. Hindfoot nail as a primary treatment has a debate, but I don't think with Weber B. So the debate was more more aggressive pattern of fracture, like a trimal or bimal or a trimal. But for a Weber B, you need to fix, and fixation will need to be very strong. And even in the bimal and trimal, still there is a debate about primary fusion versus very good fixation and later fusion if the fixation failed. But yeah, hindfoot is an option. Think about any question, guys, and I hope there is no question because you understand the lecture very good. This will be a great success for myself. Foot and ankle topics are not the easiest, especially if you are not practicing or you don't have a proper foot and ankle placement. But I promise you, it will be an easy one by the end of this course. Diabetic foot, I understand not everyone likes it, but I do like it because basically you really help the patient. So you really see a patient happy. You really see a patient saved, either saved life or saved limb. So all the best, guys. Any question, my mobile number and my email in the chat. Waiting for any question. If you need any question, happy to discuss any clinical case. If you have any clinical case, I do a proper diabetic foot service. So if you're around the area, you can refer us diabetic foot to Wixom Park Hospital. But Sam is asking, is rigid fixation means more than 2 syndesmotic screws and distal fibular locking plate? Distal fibular locking plate, yes. Syndesmotic screws, if you will do, you need to use a quadricortical, so 4 cortices, and you need to use at least 2 to 3. There's a big discussion about the biomechanical analysis and the transfibular tibial screws, and this is another big debate. But if I'll be fixing, I'll be putting 3 screws, quadricortical through 4 cortices, and fully threaded definitely as a positional screws to have a very proper fixation. This patient, remember, is neuropathic. You need him or her to wet bear early. And to be safe to wet bear this patient early, you need to have a very, very rigid fixation. And you need to be sure that your fixation is rigid enough. Any more questions, guys? You're welcome, everyone. And yeah, we shall bring this meeting, this lecture to an end. Any question, more than happy to receive it, and see you next Friday. Good luck and good evening. Thanks, Hassan.
Thank you, Mr. Hashim. Thank you for today.